So, moving on to the gram-negatives. We have done the gram-positive cocci. Now, if we were simply comparing cocci, the gram-negative cocci are a much smaller group, although there are a couple of important members. But Staphylococcus and Streptococcus we're already done with. Out of the gram-negatives, realize Neisseria is the major group. We certainly have a couple of others, Moraxella and Villanella, who will need to be distinguished from Neisseria, mostly to evaluate the likelihood of severity of a problem. But the truly important group is Neisseria, and we've got two important species. Now, if you recall, as we were talking about the gram-positive cocci, I said to you that the first test that you want to order is going to be a catalase test, that Staphylococcus is going to be catalase positive. And notice the little memory tool here. I can spell cat out of Staphylococcus. I can't spell cat out of Streptococcus. So Staphylococcus is my catalase positive, Streptococcus is my catalase negative. Now, as I move into the gram-negatives, the most important test for you to know is the oxidase test, because what this tests for is the presence of cytochrome C oxidase. And realize for organisms who have that enzyme, they use it as their terminal electron acceptor. And so if I take colonies and flood them with phenylenediamine and get the result of a black deposit forming, then I know my organisms are oxidase positive. And if I do not get that black pigment, I know that they are oxidase negative. Now, in case you lapse into a coma as we're going through the remainder of this chapter, realize that we will be in the oxidase positives until we turn the page into the family Enterobacteriaceae. Once we get to the Enterobacteriaceae, which are facultative anaerobes, they do not use cytochrome C oxidase. So when they do need a terminal electron acceptor, they have to use another molecule. And then our last one in the chapter of the normal bacteria would be Bacteroides, which is an anaerobe. And obviously, if I'm an anaerobe, I do not need cytochrome C oxidase. So, speaking of Neisseria, realize we have Neisseria meningitidis and Neisseria gonorrhea as our two groups. The rates of infectious disease with Neisseria meningitidis are basically younger than a year, and then again in adolescents and young adults. So it's a bimodal distribution. The one that is the most common problem in the United States is serogroup B. And remember, that has a sialic acid capsule. So that one is not protected against by the vaccine. It is indeed protected against by the new vaccine, which uses outer membrane proteins. But for the conjugate vaccine that takes the capsular polysaccharides of A and C and W and Y, that one is only for those groups and not for B. Now, the incidence worldwide has diminished tremendously since the advent of the vaccine. The organism is transmitted by respiratory droplets, and after colonizing the oropharynx, remember we spoke already about the issue of being a natural transformer and therefore able to acquire new capsular types that are resistant to the immune response. Neisseria gonorrhea is the number 2 sexually transmitted infection in the U.S. It's the second most common reportable disease in the U.S. Sexually transmitted, increasing amounts of drug resistance, which started with a beta-lactamase and are now moving into other avenues as well. So when we think about the meningococcus, remember that these are distinguished by the fact of whether or not they ferment maltose. So the meningococcus is the one that ferments maltose and glucose, notice, I've got an M and a G in that word. The gonococcus is the one that does not ferment maltose and ferments only glucose. But as we look first at the meningococcus, realize we're talking about agents of meningitis now. And so I'm going to have a very abrupt onset of high fever, headache, prostration, and a petechial rash, which becomes one of my most important criteria. Because remember, the thing about the pathogenesis of this organism and this genus in its totality is that it overproduces outer membrane fragments. Now, some books will make a big deal of this being a lipo-oligosaccharide instead of a lipopolysaccharide, but when I ask myself if I should care, my answer is usually not very much, because lipo-oligosaccharide binds to the same receptor that lipopolysaccharide does. So I'm going to get exactly the same effects of binding to CD14 and TLR4 and activating the production of tremendous numbers of cytokines. So personally, that's not something that makes a big deal to me. Now, remember, what's going to be important in meningitis is age. We talked about the meningitis agents, some of them at least, in the neonate, number 1 being GBS, number 2 being E. coli, number 3 being listeria. As we move into adolescence, or persons who are in crowded living situations, then it's because of the high transmissibility of the organism that I get a very rapid spread through these groups, where housing, dormitories, and barracks and so forth are crowded. Because of the overproduction of outer membrane fragments, I have very rapid mortality in this case. So you'll notice when we speak about therapy, I'm going to recommend that we treat empirically when we have a suspicion, because any delay in empiric therapy is going to result in many more deaths. So this is a medical emergency. In the CSF, I would find gram-negative kidney bean-shaped diplococci, culture on chocolate agar, and of course, it would utilize maltose and glucose and be oxidase positive. Now, when we speak about the pathogenesis, realize the majority of the adherence is mediated through the production of an IgA protease. That allows it to destroy the local immunity, so that as it moves from the oropharynx into the blood, it then uses its capsule to protect it against neutrophilic destruction and manages to make it to the blood-brain barrier and pass. So, endotoxin shock, terminating in what we call Waterhouse-Friderichsen syndrome, where the adrenals are simply converted into sacs of clotted blood. Terribly dire condition. The most common type, as I said, is type B, which is non-immunogenic. And remember that the others are all present in the vaccine, and so we have seen diminishment of those cases. I spoke in our discussion of immunology that we can't truly explain it, but patients who have an inability to create the membrane attack complex of complement end up having more and repeated bacteremias with the entire genus. So for some reason, complement-mediated lysis is important in control of Neisseria, and if I can't do it, then I've got a problem. Therapy, cefotaxime, ceftriaxone, with or without vancomycin, and again, institute therapy before you have proven the cause. This is a medical emergency, and if you delay, your patient is going to be dead. Okay? Anytime we mention rifampin being used, what we're talking about is diminishing the amount of organism found in saliva. And because of the fact that rifampin reaches very high rates in saliva, we can use this in outbreaks in order to diminish transmission. Okay? Neisseria gonorrhea, our other important species, is going to cause painful urethritis in the male, or profuse vaginal discharge in the female. It is an STI, so you're looking for an age group of patient that is sexually active. I would find gram-negative diplococci inside neutrophils on the exudate, or I could grow it on Thayer-Martin, which is a selective medium, which will inhibit the normal flora by the addition of antimicrobics, antifungals, etc. Remember that what unifies the sexually transmitted infections is the fact that these are very fragile creatures. So the requirement for transmission is that one nice warm incubator inoculates it into another nice warm incubator, if you know what I'm talking about. So when I find one STI, the clinical necessity is that I must test for all. It indicates that that patient in front of you is utilizing risky sexual behavior, and therefore I should check for all of the other possibilities. Now, when I say that I will find gram-negative diplococci inside neutrophils, I want to make certain that you understand that this organism is not a facultative intracellular. And the reason why I emphasize that is because first aid says it is. Okay? That, in my opinion, is an error in first aid that demonstrates that many of the people contributing don't really understand the depth of the material that they're memorizing. And I always want my students to think things through and ask themselves questions. If I find something inside a neutrophil on a diagnostic specimen, does that mean that that creature is living inside that neutrophil? Well, no, it doesn't, because remember what my neutrophils do is they eat as much as they can, and then when they're frustrated by their inability to eat anymore, they explode. So the normal lifespan of a neutrophil is a day or two. Things don't live inside neutrophils. Remember, my facultative intracellulars live inside my mononuclears. And these are not mononuclears that are infiltrating into the area. So don't fall into that trap. Facultative intracellulars are a very unique group that actually live inside my antigen-presenting cells. And my neutrophils are not antigen-presenting cells. Okay, so finding it inside neutrophils on a diagnostic specimen simply reflects the fact that my neutrophils are attracted by an extracellular organism, are eating as much as they possibly can, and are exploding. Now, realize that this particular species does not have a capsule. It's a fragile creature, as are most other STIs. It uses pili for attachment, and those pili undergo antigenic variation. We estimate that there are over 1 million different pilus types, so realize that that means there is no immunity to reinfection within this infection. Therefore, if you wanted to try, and I'm not recommending this, you could get Neisseria gonorrhea 1 million or so times without exhausting the pilus repertoire of antigenicity. It's also an IgA protease producer, but remember, I distinguish it because it doesn't oxidize maltose, it only reduces glucose. Now, we treat with ceftriaxone. Remember, lots of drug resistance occurring in this group, most of which is plasmid mediated, and I spoke before about the fact that it is on non-conjugative plasmids. So it takes 2 plasmids to actually transfer this via conjugation. This, of course, can spread to causing arthritis. It's usually monoarticular, but it may be multiarticular, more common in a female patient because of the fact that females tend to go undiagnosed for longer. The septic spread is assisted by the fact that the endotoxin-like molecule acts on endothelial cells and makes them leaky. We treat with ceftriaxone plus azithromycin, and again, always contact tracing and be aware of multi-drug resistance. If this organism is transmitted to a child passing through the birth canal, this can be a very dangerous condition. As always, you would have a tremendous amount of purulent exudate anywhere you find Neisseria, and so this can very rapidly lead to blindness. This is one of many reasons why we treat neonatal eyes with erythromycin ointment. It takes care of Neisseria, it takes care of treponema, and to some extent at least it deals with chlamydia, which are all of my agents of ophthalmia neonatorum. A lesser member of this group, Moraxella, is one that I typically simply need to distinguish from others by virtue of the fact of remembering that not all gram-negative diplococci are Neisseria. So this is one of those things that if I found it in an oropharynx, I need to make certain that it's not gonococcal pharyngitis and it's not Neisseria meningitidis. It looks exactly like its cousins, but it's distinguished by an enzyme test for butyrate esterase, which is a very rapid biochemical diagnostic. It's normal flora, and it can cause upper respiratory tract infection, generally pretty minor. We treat with amoxicillin and clavulanate. So here we are at the gram-negative bacilli, which is a very, very large group of organisms, as you'll see, but the greatest majority of these are not going to be as important as the things we've already left behind. So remember, for some time as we go through the pages, we will be in the oxidase positives until we enter the family Enterobacteriaceae. It does not use cytochrome C oxidase as its terminal electron acceptor, and Bacteroides, as I said before, is an anaerobe, so it does not need a terminal electron acceptor. Now, looking at the oxidase positives, notice that we would talk about most of these being relatively minor. I'll go through them in order from the aerobes into the facultative anaerobes. And remember that once I get to the microaerophiles with Helicobacter and Campylobacter, those guys are going to require growth in a special incubator, which is likely to need to be mentioned to you. Within the Enterobacteriaceae, which are a major group, notice I distinguish between them by which ones are lactose fermenters and which ones are not fermenters of lactose. The lactose fermenters spell Ceek, as you notice, C-E-E-K, and the non-lactose fermenters spell ships. So the mnemonic that I have been using for many years is Ceek ships to give you the entire group. Notice that the SH and YPS portion of that memory tool is separated the non-modal ones who don't produce gas and the modal ones who do produce hydrogen sulfide gas. Okay? Starting out with our oxidase positive aerobic gram negatives, our first one, Bordetella, who remember was bored as Hella and therefore was not one of those that required cysteine and iron. Remember, this is the agent of whooping cough, and it has been diminished greatly by the vaccine, which has been in use for many decades. But unfortunately, some people choose not to vaccinate, and we have seen the advent rise since the introduction of the vaccine caused it to fall originally. Remember that we do not vaccinate for Bordetella outside of childhood. So once one is an adolescent and an adult, Re-exposure simply resembles the common cold. This is the reason why you will probably see a change in the recommendations from the Centers for Disease Control before too long that will suggest that people in the grandparental age group should get vaccinated again to make certain that they are not transmitting to their unvaccinated grandchildren, those who are simply too young to be vaccinated as yet. It's transmitted by respiratory droplets. So chief complaint, cough and fever. And so they're going to have to suggest to you that the child is either young enough to have not received the first series yet or is unvaccinated. And depending upon what stage of disease, they're going to describe it in different ways. Notice that the catarrhal phase simply looks like an upper respiratory tract infection. Rhinorrhea, malaise, sneezing, fever. And this is actually the period of time when there is the greatest possibility of transmission because of the fact that there are large numbers of the organisms being coughed out during this phase. During the paroxysmal phase, when you move into a period where the child can get into fits of coughing 2 to 4 weeks after the initial upper respiratory tract appearance, you'll get the classic sound that we associate with the name of the disease. Remember, it's called whooping cough, and I've always thought that this is sort of a misnomer. I've thought it should be called coughing whoop, because the sound that is unusual truly comes on inspiration. So when the child inhales, that's when you hear that sort of strangulating sound, the stridor of them trying to get a breath. These fits can lead to vomiting. They're also associated with leukocytosis. And even during the convalescent phase, which can go on for the final 4 to 6 weeks after exposure, I have the potential for secondary complications. Because remember, what happens in the fits of coughing is that I damage blood vessels and cause them to be prone to hemorrhage. So I can see subconjunctival or cerebral hemorrhages happening in this point. It's just as dangerous in the convalescent phase as it is in the paroxysmal. Now, as far as the pathogenesis, the organism attaches via its filamentous hemagglutinin. And remember, we put that in the vaccine. It is encapsulated. And remember that the toxin is the one that ribosylates G sub I, promoting edema. It also causes lymphocytosis, sensitizes to histamine, and enhances insulin secretion, which leads to hypoglycemia. The tracheal cytotoxin and the dermonecrotic toxin both cause necrosis of tracheal tissues, and the adenylate cyclase toxin is the one that inhibits chemotaxis and neutrophil function, in addition to adding on more edema. So we treat with macrolides. The vaccine is now an acellular one. That's what the AP stands for. Remember, it's a filamentous hemagglutinin plus the toxoid of the organism. Brucella is our first sister Ella. So realize that means requiring cysteine and iron. This is also our first zoonotic. And just briefly, a zoonosis is a disease of animals that's transmissible to man. The states with highest incidence are California and Texas. Remember, anytime you see mention of geography on an exam question, they're doing that for a reason. Travel to Mexico also could be mentioned. And remember that there are 3 different species. Melitensis I mentioned first because it actually causes the most severe infection. Abortus comes from cattle. Suis from swine. Now, these are all conditions of chronic fever, sometimes peaking at night, chills, weight loss, altered mental status. It is a granulomatous septicemic condition and a facultative intracellular. Any sort of mention of a history of occupational or other exposure to animals is a very good clue, but diagnostically we really do this by serology. And remember, if they mention a specific serologic test, they would have to say something like antibodies for Brucella melitensis were found, or antibodies to Brucella abortus were found. So I need to remember that it's a problem for them to compose a challenging question. Now, this organism is another one that is on the bioweapon watch list. And I mention that only in passing because of the fact that we discussed that briefly when we were talking about anthrax. Remember, in anthrax, it's on the bioweapon watch list because it's relatively easily weaponized in its spore form. This one is on the bioweapon watch list because it's amazingly transmissible. And so its transmission person to person and animal to person is very important to remember. I treat with doxycycline and an aminoglycoside. Prevention, we have vaccines for many domestic animals. In the case of humans, we pasteurize any dairy product, but there is no human vaccine. Our second sister Ella, requiring cysteine and iron, is also a zoonosis. Francisella, also on the bioweapon watch list for the same reason as Brucella. So notice exposure to rabbits, deer, or rodents, and the key states, Arkansas, Missouri, or Oklahoma. So they're likely to mention a patient being a hunter of one of these animals. Transmission is via a variety of different ways: aerosol, implantation, ingestion, tick bite, the same tick that transmits Rocky Mountain spotted fever that we'll talk about toward the end of this chapter. Notice the comment that culture is hazardous, which should imply to you that we have a fairly good number of laboratory-acquired conditions if people are not aware of what they're trying to culture and do not take precautions in the laboratory. Now, the chief complaint depends upon how you introduce this into the body, but generally fever, chills, malaise. Again, it's a granulomatous septicemia, but if it's only introduced to the skin, I can have an ulcer, I can get it into the eye and cause conjunctivitis, I can ingest it and have something that sort of mimics typhoid fever, or I can inhale it, in which case I have a profound infection in the lung. So pneumonia would result from that. As I said, ingested resembles typhoid fever, traumatically implanted granulomatous ulcers. I treat with streptomycin or gentamicin. For vaccine, there is a live attenuated vaccine, and of course my at-risk groups would either be hunters or persons who handle the animals from whom the zoonotic originates. Now, Legionella, our third sister Ella, so we're going through a bunch now that require cysteine and iron, but Legionella is now our most common atypical pneumonia of the elderly. It is acquired from aerosols of water sources, and as you'll see, these organisms do not get killed by our standard water purification techniques. They resist chlorination and heat. So in common sources of water, I have to use heavy metal ionization systems in order to dispose of them. Now, very importantly, because I know that this has been a subject of questions before, there is no human-to-human transmission. And the question I've heard about is asking if a family has a grandparent who has acquired Legionnaire's disease, is it necessary to avoid that grandparent seeing grandchildren, etc.? And no, it's not, because there is no human-to-human transmission. If I have a case of Legionella, I need to find the source of the water contamination and deal with that. I do not need to worry about human-to-human transmission. So, atypical pneumonia, we've spoken about this before. It's going to be febrile, dry cough. Notice that this is unusual because of the fact that I also see mental disturbances and diarrhea. And we do not have a good explanation of that because there are not any bacteria in the brain or GI. We think it's due to the organism causing hyponatremia, but we're not entirely certain. The only thing I want to make certain you notice is that this is the only pneumonia that will be associated with mental confusion and diarrhea. So that becomes an important point for you to notice as you're reading case histories. The typical patient is an elderly smoker, has high alcohol consumption, or immunosuppressed. That sort of describes the attendees at the Legionnaire's Convention in Philadelphia when this was the first outbreak. It is going to be stained with a silver stain if you do a biopsy, but there is an antigen test used for urine at the current time, which makes for a quick diagnosis. Only problem with urine tests, remember, I've actually now got a urine test for virtually every type of pneumonia that we've got. So they will not be able to simply say urine test was positive. They'll have to tell you which one, and then, of course, that gives you the diagnosis. We grow it. It's very fastidious, so buffered charcoal yeast agar gives it the requirements of cysteine and iron it needs. It's a facultative intracellular, okay? So once again, realize all of these that we've recently been in are going to be in the APC1, TH1, APC1 loop. So it shouldn't surprise you, I hope, that these are all atypical pneumonias, because typical pneumonias are caused by neutrophils infiltrating, not the cells of the cell-mediated cascade. Okay? So facultative intracellular dictates that it will be a atypical pneumonia. It produces a toxin that kills macrophages, and the alveoli will fill up with the responding cells. I do not have any bacteria, as I said, in the brain or the GI. I treat with fluoroquinolones, azithromycin, erythromycin, add rifampin for the immunocompromised. Pseudomonas is another organism that comes from water sources, but this one is susceptible to normal chlorination, etc. It's transmitted by direct contact, trauma, or aerosols, depending on which of the presentations we're talking about. It is generally the #1 cause of death in cystic fibrosis patients. It's going to present when a pneumonia with cough and fever. Okay, the patient population would be persons with cystic fibrosis, problem being that their neutrophils are already overwhelmed dealing with the amount of abnormal secretions that they make. And remember, what is the most important pathogenic feature of this is the huge capsule, which impedes phagocytosis. Neutropenic patients would be at risk, CGD patients because it's catalase positive. It produces blue, green, and fluorescent pigments. And this is often mentioned not only coloring the sputum blue-green, but also if I had a pseudomonal wound infection, finding that it would color any dressing that I put over that wound. It has an unusual grape-like or fruity odor, and realize gram stain culture would mention a eosin methylene blue agar, that these are non-fermenters, which reflects the fact that this is an obligate aerobe. Okay, now as far as the eye ulcers are concerned, these would be associated with persons who poorly maintain and extend the wear time of contact lenses. If it results in hot tub folliculitis, remember that the rash and lesions are going to be below the neck, because most people don't sit in a hot tub totally submerged. In patients who are catheterized, I can anticipate having it introduced into the urinary tract and causing dysuria. And in burn patients, I can develop septicemias, as well as in neutropenic patients or CGD patients. When I have a pseudomonal septicemia, remember the classic lesion is called ecthema gangrenosum. It does resemble the anthrax eschar, but of course, anthrax is going to be an entirely different patient population and presentation. It's just that the lesion is going to look superficially similar. So fever, confusion, those black necrotic skin lesions in a person who has developed septicemia. It would be the same mechanism of pathogenesis to some degree in all of these. The exotoxin that it makes, remember, shuts off protein synthesis, targeting the liver. In the case of development of shock, endotoxin always plays a major role because of its action on the endothelium. And the elastase that the organism produces destroys blood vessel walls and contributes to the appearance of ecthema gangrenosum. Remember, this is one of the most drug resistant of any of the bacteria we will talk about. So although you will start with an anti-pseudomonal penicillin and an aminoglycoside, it is very, very common for you to have to switch over midstream once you get the susceptibility testing results back. Very strong disinfection of any material that contains water in a hospital or clinic is really the best way. So refrigerator casings, incubator trays, sink drains, all of those respiratory equipments, all of those need to be stringently disinfected in order to prevent transmission of this to a debilitated group. So as we enter the next group, which is the gram-negative oxidase-positive facultative anaerobics, notice that these guys sometimes have unusual intermediate shape. When we talk about a coccobacillus, we're talking about something that can look somewhat intermediate between a sphere and a rod, okay? So Pasteurella is our fourth sister Ella, okay? Our final one that requires cysteine and iron. And then I just added on here, for the sake of finishing off a topic, a mixed bag of things that you can get from being bitten by something, okay? The reason I wanted to handle these all together is that Pasteurella is very common in animal mouths. So it would be the most common thing that you would get from the bite of an animal. But remember, there are other things that predominate in other animal mouths. And our therapy or our management clinically of bites is always the same. When you get someone into the clinic that has been bitten by something, first of all, of course, you would consider the potential for rabies, if that were even a thing. But if not, you would clean out the bite wound as best you can. Perhaps, depending on severity, send them home with a regimen of antibiotics, and that would be it. We don't culture bite wounds. So I didn't think it was worth going into great detail on the vicissitudes of the differences between these. But if a person has been bitten, so the most common thing that you would find in the mouth of the cat would be Pasteurella. Remember, cat scratches can give you Bartonella henselae, cat scratch disease, and additionally, I can get bacillary angiomatosis, same organism, in my AIDS patients. With the dog bite, I would anticipate Capnocytophaga canamorsus. And if there has been a human fight or brawl involving biting and fighting with fists, Eikenella corrodens is the normal flora of the mouth that can cause infections of the fist as it hits that normal flora site. Rat bites would be known for Streptobacillus moniliformis. Now, all of these are gram-negatives. They all are encapsulated, so they tend to cause similar presentations. Treatment, as I said, would be amoxicillin and clavulanate. So other than that, I think the only thing that they could ask is what would be the most common thing to worry about from a dog bite or a cat bite or a rat bite. And other than that, I just don't think it's too much to worry about. Haemophilus is certainly a different story. Haemophilus remains a heavy subject of questioning because it's one of those cases where we can truly congratulate ourselves about the rather clever design of the vaccine that was introduced in the early 1990s. So this is an agent of meningitis and epiglottitis, but at the current time it would be only unvaccinated children, 3 months to 3 years of age. Okay, transmission is human to human via respiratory droplets. And remember, there are also strains that will cause otitis media, and unfortunately, those strains are not protected against by the vaccine. Any of the invasive disease forms are indeed protected against by the vaccine. So bronchitis and pneumonia in smokers or patients with COPD also are from the normal strains that we have in the vaccine. Now, as far as meningitis is concerned, headache, fever, stiff neck, remember with meningitis, we always first consider the age. So 3 months to 3 years of age, an unvaccinated child. Typically, it's the type B that causes 90% of our invasive disease in the United States. I grow it on agar that has lysed red blood cells because it requires factors X and V for growth. That's found in the erythrocytes, but I have to lyse those and use chocolate agar in order to get it to grow. The capsule, remember, is a polyribitol phosphate capsule, and the organism is an IgA protease producer. Treat with cefotaxime, ceftriaxone. Rifampin is given, as we mentioned before, to cut down on transmission during outbreaks. And remember, very importantly, immunologically, you have to know what the strategy is behind conjugating this to the diphtheria toxoid. If you do not remember that, go back and review the vaccination chapter out of immunology. Haemophilus do cry, our memory tool here. You do cry with do cry. It's a painful genital lesion, sexually transmitted, human to human. It causes cancroid is the name of the disease, but a painful genital ulcer. And remember, this is not common in the United States, so they'll have to give you some sort of history of travel and unprotected sex. It again requires factors X and V, so it grows on chocolate agar as its cousin Haemophilus influenza does. It has pili, which it uses for attachment, and a cytotoxic toxin that will kill T lymphocytes. Treat with azithromycin, ceftriaxone, cipro, erythromycin. Safe sex, always a better idea than not. Now next we're going to get into a group of curved rods, okay? Gram-negative still, oxidase positive still, facultatively anaerobic, but these guys all are curved rods. Vibrio, transmitted human to human by fecal-oral contamination. There is no carrier state, and that is one of the things that they like you to understand. Realize that this has a very high infectious dose, 10 to the 7th organisms or more, so not common in the United States unless there is a tremendous amount of poor sanitation. Remember that when we speak about a high infectious dose, we're talking about an organism that does not survive the gastric acidity very well. So I have to have a massive dose so that even some survive through the acidity to cause problems on the other side. And that's why we mention shellfish and seafood, because seafood, when it's uncooked, and shellfish, because they're filter feeders, will actually filter the debris out of the water they live in. And if it's less than clean water, they will simply collect it for you. Now, Vibrio cholerae is an agent of extreme watery diarrhea. The toxin, if you recall, ribosylates G sub S alpha and activates adenylate cyclase, so I get the fluid loss that you would anticipate. Realize it also is a mucinase producer. And so when you see the description of cholera stool, they'll talk about rice water stools, reflecting the fact that I'm seeing those flecks of mucus on the surface of water that is simply diarrhea to the point of hypovolemic shock and electrolyte imbalance. Now, this is not going to occur in the United States. They're going to have to mention immigration or travel to an area where sanitation is profoundly debilitated. We associate it often with natural disasters, because one of the first things that happens in a natural disaster is that the water treatment facilities become crippled. The treatment, really supportive care, is all that's necessary. The problem is that in an outbreak, you can very quickly get to the place where you don't have enough fluids and electrolytes to keep people alive. And children, of course, are profoundly susceptible to the rapid electrolyte imbalances. In some cases, they've shown that doxycycline or Cipro have shortened the course, but in general, because it's toxin-caused, supportive care truly should be enough. There are vaccines for travelers. However, I have never known them to ask about the specifics of those vaccines that are not in common usage in the United States. Sanitation, chlorination of water, cook your foods. Always good ideas. Now, the other two, Vibrio parahemolyticus and Vibrio vulnificus, are going to be capable of causing a similar watery diarrhea if the exposure is marine, poorly cooked seafood. I, as a microbiologist, do not do sushi, and I apologize for anyone that I have offended by saying that. But cooking food is generally a better idea than not. Vibrio vulnificus is one that I mentioned to you back when we were talking about Mycobacterium marinum, if you recall. And I was saying, if one were to make a category of things that you get that cause lesions on the hand when you have exposed your hands long-term to water. Remember, Mycobacterium marinum was the one that caused the fish tank granuloma that we spoke about. Vibrio vulnificus enters into wounds that are achieved when one is trying to open up the shell of a shellfish. And so it's a rapidly ulcerating abscess. Remember, I said to you that Mycobacterium marinum is going to be an ulcerating granulomatous condition because of the fact that Mycobacterium is facultatively intracellular, Vibrio is extracellular. We treat with tetracyclines or third-generation cephalosporins. Continuing in the curved bacilli, we have Campylobacter. Notice the distinction as we enter this group is that it's a microaerophile. So that means I'm going to need to grow this in a special incubator into which I pump CO2 when I close the door. So a 5, 6, 10% CO2 incubator. Now, surprising to many people, this is the #1 cause of bacterial gastroenteritis in the United States. And every year, if I were simply looking at agents of diarrheal disease across the board, there are 2 organisms that would win the prize virtually every year, and I think the other one will surprise you as well. It is Giardia. So typically we don't think of parasitic problems in the United States, but in fact, Giardia is much more common in the US than it is in most other countries. So I'm not saying that you would have any trouble distinguishing between these. I'm simply saying, remember, these are top of the list as far as agents of diarrheal disease. Now, Campylobacter comes from fecal oral contamination from poultry. About 25% of cases will go on to develop Guillain-Barré syndrome, and that is quite a high number. Remember, our other sources of Guillain-Barré are typically viral, like influenza. And we do know in this case why it is that this is associated with Guillain-Barré, and it's because of molecular mimicry, as you'll see in a moment. Now, realize that when we divide these by chief complaint, we've got bloody diarrhea and fever as the typical Campylobacter gastroenteritis. Remember that as far as dividing these from one another, the first thing that you're going to think about is going to be the food source that the person has eaten. So some sort of mention of a poultry source. They are likely to mention unusual culture characteristics, CO2 incubator and high temperature. And sometimes it's described on gram stain as looking like a bird flapping its wings. That's because the polar flagella end up getting clumped together, and so the organism will flap those flagella and look like a bird flapping its wings. Shouldn't surprise you, as a bloody diarrhea, it is an invader of the mucosa. It has a low infectious dose, 500 organisms required to make you sick. So unlike cholera, this means this one is resistant to acid. It's generally a self-limiting problem in 3 to 5 days. So I personally would recommend simply supportive care, fluids, etc. But very severe cases can be susceptible to macrolides and fluoroquinolines. Guillain-Barré syndrome, remember that this is because of the fact that the envelope type 19, O19 serotype, has oligosaccharides which cross-react with your glycosphingolipids. And so the antibodies that are produced against the O19 serotype will then cause an activation against your own neural tissue. The way we deal with this is plasmapheresis. You try to get rid of those antibodies in order to get rid of the problem. Finally, remember that Campylobacter can be associated with the production of reactive arthritis, which used to be called Reiter syndrome, but they have slowly been getting away from eponyms on the exam. Reiter happened to be a Nazi, and so they have been sort of cleansing those names from the literature. This is an HLA-B27 linked arthritis associated with the same old things. Remember, you can't see or pee or climb a tree. So urethritis, cervicitis, arthritis, conjunctivitis. Again, it's a cross-reactive response immunologically. Treat with tetracycline and analgesics. Helicobacter. Human to human, fecal oral, and oral transmission. Okay. Helicobacter is another rod with an unusual shape, but this one is more of a spiral in shape. Spiralar rods instead of simple curved. The presenting complaint is going to be dyspepsia and epigastric pain. This, of course, is the one that's associated with gastritis and ulcers, and in later periods of time can associate with the development of cancer. Okay? Diagnosis by biopsy, grows at normal temperature, although again it is microaerophilic, so I would need to grow it in a CO2 incubator. But my diagnosis is typically by an antigen test on the feces, or they like to mention the breath test, which requires the swallowing of a small amount of radiolabeled carbonuria if the patient is secreting urease in the stomach because of the infection. Then what will happen is that they will exhale that radiolabel on the CO2 as they exhale. Now, not all hospitals have that equipment, so the fecal antigen test is actually probably more common currently, but the urease breath test is often mentioned because of the fact that it highlights that most important of pathogenic features here. What urease does for this organism is allows it to survive in the stomach acid. So by altering the pH in the area, then the organism uses its motility to assist it in invading. It produces a mucinase, which dissolves the mucus protection over the stomach, a cytotoxin, which kills cells and promotes inflammation. So over time, the development of cancer near the incisura or maltomas, mucosal-associated lymphoid tissue, B-cell lymphomas, result from the fact that the organism causes continuous inflammatory cycles over and over again. Remember that the type 4 secretion system is encoded in that same pathogenicity island that we call CAG, and that CAG island is responsible also for the production of the long-term malignant transformation. Treatment, bismuth salts plus 2 antibiotics, usually amoxicillin or clarithromycin, metronidazole or tetracycline. The problem, of course, is getting something to work as an antibiotic in the gastric acidity where the ambient pH is very low. So I think that's a good place to stop for now, and we'll pick up next time discussing the gram-negative oxidase negatives, because we will be entering the family Enterobacteriaceae.